Good morning. Today we are discussing about the echocardiographic evaluation of mitral valve. The main questions to be answered by cardiac imaging are: what is the mechanism of MR? Mechanisms are leaflet motion by the Carpenter classification. Second is leaflet morphology. What is the severity of the mitral regurgitation? Are multiple parameters internally consistent? Beware of the common pitfalls. Further testing needed or not? What are the consequences of MR on LV, LA and pulmonary circulation? Normal LV and LA volumes and RV systolic pressures are not consistent with the severe MR. What is the mechanism of MR? One is based on the leaflet morphology, leaflet motion by the Carpenter type, subvalvular involvement, annulus dilatation of calcium, LV size and function, LA size and function. Is the MR severe? By quantitative method, effective regurgitant orifice area, then the regurgitant volume, regurgitant fraction, qualitative by multiple methods. We will discuss it later. What is the effect of MR on LV and LA size and LA by pulmonary or pulmonary venous pressure? LV diameters, volumes, LV ejection fraction, GLS, fibrosis, LA volume, pressure, estimated PA, systolic pressure. Then are there anatomic features that support or preclude a given surgical or transcatheter approach? Annulus size, leaflet length or thickening, subvalvular pathology, mitral annular calcium, potentials for LVOT obstruction, others device specific. One is anatomic assessment of mitral valve. There are 5 mitral valve components. One is leaflet, second is chordae tendineae, then papillary muscle, fourth is annulus, commissures, LA and LV. There are 2 leaflets with 3 scallops. Anterior mitral leaflet, which is larger and thicker and is dome shaped. Okay, look here, this is the anterior mitral leaflet and which is larger and thicker and it is dome shaped. Okay, then scallops A1 is lateral and A2 is this is the A1 scallop which is lateral and A2 is central and A3 is the medial scallop. Okay, then the posterior mitral leaflet, this is the posterior mitral leaflet and which is thinner and more flexible and which is crescent shaped. Scallops P1 is lateral, P2 is central and P3 is medial. Leaflets thin and pliable. Scallops serves as segmental markers of the leaflets. Then posterior leaflet is short in length, usually 11 to 14 mm. Anterior leaflet is longer, normally 18 to 24 mm. Okay, this is the picture. You already got an idea, I think. This is the lateral leaflet A1, A2 is central and A3 is the medial. P1 is lateral, P2 is central and P3 is the medial leaflet. Okay. Then next is in each view we can assess the mitral leaflet. This is the parasternal parasternal long axis view, flax view, where we can assess the A2 and P2. Okay, that is both the central anterior mitral leaflet A2 and P2 in the parasternal long axis view. Okay, then in the 3-chamber view. Okay, look here, this is the 3-chamber view. Also we can assess the A2 and P2. In the 2-chamber view in the echo we can assess the P3, P1 and A2. Look, this is the P3. P3 is the middle one, P1 is the lateral one, and in the anterior you can assess A2, A1 and A3. Okay, understood? In the short axis view we can assess A3, A2, A1, P3, P2, P1. Okay. Then the second anatomical assessment of the mitral valve is a chordae tendineae. Chordae tendineae is a fibrous strings that attach specific portion of the mitral leaflets to the papillary muscle tips. Normal average length is around 20 mm. Normal average thickness is 1 to 2 mm. Look for thickening, fusion, calcification, elongation, rupture. Look, this is the chordate tendineae. Okay, chordate tendineae, primary chordate tendineae, and this is the primary, this is the secondary, this is the tertiary chordate tendineae. Understood? The primary chords insert into the free edge of the leaflets adjacent to the zone of coaptation. Primary chords prevent leaflet prolapse by ensuring leaflet tip coaptation throughout the system. The secondary chords insert into the body of the ventricular surface of the leaflets and bear the significant systolic load by spreading it evenly throughout the leaflets. The tertiary chords insert into both the base of the posterior leaflet and basal LV wall, connecting the posterior leaflet and annulus to the papillary muscle. Third is the papillary muscle. Papillary muscle, anterolateral papillary muscle, is usually the largest, comprised of two heads arising from a single projection at the mid to apical border between the lateral and the inferior lateral wall. The posteromedial papillary muscle extends from multiple myocardial projections from the mid to apical inferior wall, comprising three heads: anterior, intermediate, and posterior. This is the short axis view showing the posteromedial papillary muscle and the anterolateral papillary muscle. Fourth one is the mitral annulus. The posterior mitral annulus is muscular. The anterior annulus consists of fibrous tissue made up of the left and the right trigones. This is the anterior annulus, which is fibrous tissue made up of left and right trigones, and this is the posterior annulus, which is muscular. The fifth one is commissures LV and LA. Two specific sites where the leaflet insert and join into the mitral annulus: anterolateral commissure and posteromedial commissure. This is the anterior leaflet which insert to the mitral annulus by the anterolateral commissure, and this is a posterior leaflet insert into the mitral annulus by posteromedial commissure. Understood? I think you understood the mitral anatomy. This is the left atrium. This is the mitral valve. These are the chordate tendineae. This is the LV. These are the papillary muscles. Understood? Then mitral valve zones. The body smooth zone, surface area on the leaflet body. Coaptation rough zone represents the coaptation area of the leaflets, the crucial area to observe in assessment of the mitral valve function. This is the smooth zone or body, and this is the coaptation zone is the rough zone. Understood? Coming to the mitral valve imaging orientation. Four standard views to visualize the mitral valve. One is parasternal long axis view, parasternal short axis view, apical 4-chamber view, and apical 2-chamber view. Okay. We already discussed in the parasternal long axis view, which is this view, we can assess the A2 and P2 simultaneously. Okay. Then the parasternal short axis view, we can assess A3, which is the medial. Look, this is the A3, A2 and A1. A1 is lateral, A2 is central, A3, and P1, P2, P3. These are the mitral valve leaflets A3, A2, A1 and P3, P2, P1 seen in the parasternal short axis. Understood? And this is the posteromedial commissures. Okay, this is the posteromedial commissures and this is the anterolateral commissures. This is the posterior and this is the anterior part. Okay, this is the posteromedial commissure. This is the posteromedial commissure and this is the anterolateral commissures. And then in the apical 4-chamber view, this is the A3, A2 and P. In the apical 4-chamber view, look, this is the anterior mitral leaflet and this is the posterior mitral leaflet. Okay. Then in the anterior mitral leaflet, we can see A3. A3 is the medial one, A2 and central one, and P1. Okay, understood? In the apical 4-chamber view, we can see the three leaflets, A3, A2 and P1. Okay. Then etiological assessment of the mitral valve. Mitral regurgitation can be primary chronic MR, secondary chronic MR. Primary MR is caused by primary abnormality of one or more of the components of the valve. Okay. We will discuss it later. Secondary chronic MR associated with LA dilatation is commonly associated with atrial fibrillation or heart failure with the preserved ejection fraction. Okay. Causes of the mitral regurgitation. Etiology: atrial fibrillation. In atrial fibrillation, the mechanism is annular dilatation, leaflet malcoaptation. In acute ischemia, there is papillary muscle dysfunction or rupture, congenital or genetic disorders, Marfan syndrome, Ehlers-Danlos syndrome, Down syndrome, which results in leaflet prolapse, cleft or rudimentary leaflets. Then endocarditis, infective and marantic endocarditis, leaflet perforation, malcoaptation, caudal rupture, which causes mitral regurgitation. Drugs like fenfluramine and dexfenfluramine causes leaflet chordae, affects leaflet and chordae, which cause MR. Functional or secondary dilated cardiomyopathy. LV remodeling, papillary muscle displacement leading to leaflet tethering and annulus dilatation. Hypertrophic obstructive cardiomyopathy results in there mitral regurgitation is due to systolic anterior motion of the anterior mitral leaflet. Then myxomatous degeneration, primary Barlow's disease, fibroelastic deficiency. Here leaflet prolapse and rupture chordae. Mitral annular calcification, annulus leaflets. In rheumatic heart disease, leaflets chordae, radiation, leaflets and chordae. Carpenter function classification of mitral regurgitation. Type 1, there is normal leaflet motion. Understood? In type 1, there is leaflet motion is normal. In type 2, there is excess leaflet motion. And type 3A, there is restricted leaflet motion, and type 3B, there is refracted leaflet motion during systole only. In type 3A, there is restricted leaflet motion in both systole and diastole. Understood? Type 1, there is normal leaflet motion. Then how there is mitral regurgitation? There is mitral annular dilatation with normal leaflets seen in dilated cardiomyopathy and in endocarditis. In type 2, there is excess leaflet motion. Usually we see in the ruptured chordae and the posterior leaflet flail. Example: degenerative valve disease, Barlow's disease, Marfan's disease, trauma, ischemic cardiomyopathy. Then type 3A, there is restricted leaflet motion during systole and diastole. Leaflets are shown thickened and retracted in rheumatic heart disease, carcinoids. Type 3B, restricted leaflet motion during systole only, tethering of the posterior leaflet secondary to myocardial infarct, dilated cardiomyopathy, ischemic cardiomyopathy. Look, type 1 normal, there is normal leaflet motion is normal. Type 1, there is the leaflet motion is normal, but there is mitral annular dilatation. Okay, the DCM endocarditis, there is excess leaflet motion because of the chordae rupture. Okay, then type 3A, both during systole and diastole. Type 3B during systole only. Okay. Then coming to the assessment of severity of the mitral regurgitation. Qualitative assessment by valve morphology, color flow imaging, continuous wave Doppler. Semi-quantitative assessment by pulse wave Doppler, pulmonary venous flow reversal, vena conductor. Then quantitative assessment by Doppler volumetric method, PISA method. First one is qualitative assessment by color flow imaging. The size and extent of the jet into the LA increase with severity of MR, we all know. The regurgitant jet more than 40% of the LA area. Understood? The 40%, but it's more than 40% of the LA area is severe MR. Large eccentric jet entering, swirling and reaching the posterior wall of the LA, significant MR. Then small jets appearing just beyond the mitral leaflets, usually mild MR. That is, in mild MR, there is less than 4 cm square or less than 20% of the LA size, 4 to 10 cm square or 20 to 40% of the LA size. Moderate MR, greater than 10 cm square or greater than 40% of the LA size is severe MR. Then continuous wave Doppler. The color flow Doppler is a primary method to evaluate the presence of regurgitation. It provides us information on first is location of the regurgitant jet, second is size of the jet, third is spatial orientation of the jet area, width and length, fourth is flow convergence into the regurgitant orifice. In the apical forewindow, look, this is the MR jet. Okay, this is the MR Vmax. Okay. Look, the type of MR, the first one is a late systolic MR. That is, in the early and mid systole there is no jet. The regurgitation to LA only in the late systolic MR. Second one is biphasic MR, that is begins even in the first phase. Okay, mild MR, there is soft density and incomplete envelope, dense signal and triangular envelope, severe MR. Okay, then in continuous wave Doppler, MR Vmax 4 meter per second indicates a low indicates a low BP and high LA pressure. MR Vmax 6 meter per second indicates a high BP and a low LA pressure. The quantity, the contour and the density of the jet can also provide qualitative information. Look, the trace or mild MR, faint parabolic, partially incomplete. Moderate MR, dense but partial or parabolic. Severe MR, polysystolic, dense, triangular, conduct, we all know it. Then second is semi-quantitative assessment, pulse wave Doppler. The inflow pattern and the velocity can help us identify supportive signs of severe MR. Apical forewindow, ultrasound beam parallel to the direction of flow. Velocity informs us of forward stroke volume across the mitral valve. E-wave dominance, supportive sign of severe MR. The increased E-wave greater than 1.2 meter per second, increased E by A ratio, shortened deceleration time. Reliable to assess primary MR, challenge for secondary, unable to differentiate between LV filling pressures or regurgitation. Dominant A wave inflow pattern excludes severe MR. Assessment of semi-quantitative method. Okay, pulse wave Doppler, mitral valve inflow, pulse wave Doppler, E wave dominant, supportive sign of severe MR, increased E wave greater than 1.2. Look here, the E wave is increased and the E by A ratio is increased and shortened. This is the deceleration time and the deceleration time is shortened. Okay, then next is the pulse wave Doppler across the pulmonary veins. Okay, if we put pulse wave across the pulmonary veins, evaluate for flow reversal and the hemodynamics due to mitral regurgitation. In the apical forewindow, sample volume of Doppler 1 centimeter into the pulmonary vein. Okay, there we get the systolic and the diastolic. S wave is disystolic and D wave is diastolic. A wave is the peak reversal flow. This is the A wave, this is the peak reversal flow. AR duration is the time of peak reversal flow. This is the AR duration, this is the time of peak reversal flow. Atrial conduction. The flow reversal pattern is present. There is greater than 85% probability of severe MR. Okay, then the pulse wave Doppler, S wave, normally S wave is greater than D wave, and if there is a atrial flow reversal, if there is flow reversal pattern present, there is 85% probability of severe MR. Okay, next is then this picture is showing the flow reversal in if present in more than one vein is specific for severe MR. Okay, this is how we can put the pulse wave across the, this is the pulmonary veins. You can put the pulse wave across the pulmonary vein. Okay, then there is blunted systolic flow, that is normally systolic is greater than diastolic. In MR there is systolic is less than diastolic, or there is flow reversal. Okay, flow reversal, systolic flow reversal, and there is atrial reversal. Okay, the normal flow pattern suggests low left atrial pressure and non-severe MR. Less valuable in secondary MR due to unable to exclude diastolic dysfunction. This is the normal. This is the normal. S is greater than D. Systolic blunted. This S is less than D. Okay, this is S, this is D, and the flow reversal. This is the flow reversal. Okay. Then next is vena contracta. The narrowest portion of the jet has emerges from the orbits. Good marker to distinguish mild MR from the severe MR. Then jet width. Okay, MR diagnostic criteria: jet width less than 0.3 centimeter, mild MR greater than 0.7 centimeter, severe MR 0.3 to 0.7 centimeter, severe. Okay. Then MR vena conductor width, how to get step by step. In the parastern long axis view, ultrasound beam perpendicular to the floor, adjust the focus setting to the level of mitral valve, zoom image, color Doppler sector narrow around the valve, maximize lateral and temporal resolution, color scale 50 to 70 centimeter per second, scroll frame by frame through systolic cycle. For the largest jet area, measure the vena conductor, narrowest portion of the jet, toggle the color on and off to better visualize the orifice. Then the pros and cons of the vena conductor. Semi-quantitative measure. A good marker to distinguish mild from severe, can be used for both central and eccentric jets, independent of driving pressure, blood pressure, etc. for a fixed MR orifice. Example, rheumatic heart, calcification, endocarditis, etc. Cons are small measurement errors leads to misclassification of MR severity, MR not holosystolic, MVP, or there is overestimation in MVP. Multiple jets underestimation, elliptical shape orifice, secondary MR underestimation. Then the quantitative assessment is PISA, proximal isovelocity surface area, Doppler volumetric method. Okay. Flow through the regurgitating orifice is equal to flow through the isovelocity surface. PISA method is able to provide us with regurgitation flow, EROA, regurgitation volume. Okay, then we can conclude till the qualitative method. We can discuss the PISA method in next class. Thank you.